Without further ado, I will introduce Dr. Nathan Rock. He is one of our optometrists here at Wang Vision, and he has been with us he's been at Wang Vision for 6 years, so great part of the team. He is a graduate of Southern College of Optometry, and he finished his residency in Portland, Oregon at the VA with an emphasis on, in primary care with emphasis on ocular disease. So he'll be leading this first lecture of the Triage and Management of Ocular Urgencies and Emergencies.
Hey everyone, thank you so much for joining us tonight. Course title's kind of a mouthful, so anyways. But yeah, we're glad you all could make it. I know we have a lot of people from Tennessee and then actually throughout the country, and I just hope everyone is doing well locally in this tough time. But thanks for taking time to be with us and learn and get some credits. Feel free to ask any questions with the Q&A throughout the lecture. And once again, I appreciate y'all joining us. So don't have any financial disclosures. And then throughout the lecture, we're going to use this grading system. So I want to start with this. It would be the two things we're going to focus on, which would be urgencies, which require swift action, versus emergencies, which are more serious and require immediate action. Ultimately, throughout, I'm going to present a series of cases, and then we're going to make this interactive to the extent we can. So I'm going to ask the audience to rate the severity of the cases on this scale of 1, which would be like a mild risk of vision loss, versus 10, which would be fatality, which certainly not something we want to subject our patients to, right? So for triage considerations, the same sort of scale, but a lot of us, myself included, started to do some telemedicine during the pandemic. And so something that could be handled over telemedicine could be considered a level 1 versus a level 10 that could require a patient to be either seen in an emergency room or possibly admitted to a hospital. So that's a good consideration to think of here on this same scale. So without further ado, we'll jump into the cases. Case 1 was an 80-year-old female that presented, and she came into the clinic wearing an eye patch. She had symptoms of redness, irritation, and soreness that had lasted for 48 hours. Medical history was relatively unremarkable. Anemic, hyperthyroid, hypertension. Ocular history, she had had cataract surgery 14 years ago. The vision in the affected eye, the left eye, was 20/40, and it did not improve with pinhole. There was a positive APD in that eye. Eye pressure was normal. And then the slit lamp exam, we did not photograph this patient, but I do have a representative photo net. So this was essentially the slit lamp exam. There was significant chemosis of the conjunctiva. There was significant injection and notable proptosis. So based on this information, I'm going to ask everyone in the audience to go ahead and rate the urgency of this clinical situation on a scale of 1 to 10, 10 being the most urgent and 1 being the least urgent. So I did go ahead and launch that poll, and we'll give everyone a little bit of time to vote. This is kind of a fun way to do it, and not something we can always do in a lecture hall as easily. Certainly is an option, but a lot easier when you can just click right on your computer screen. And they do tend to be kind of a nice even distribution often. Okay, so we have the vast majority participating. I'm going to go ahead and end that poll. And we see then distribution kind of around 8, going down as low as 4 and as high as 10. So let me show everyone. So there's our results. And it is interesting to see how everyone will grade these. So differentials would be At this point, orbital cellulitis, it had a lot of features of that, including some of the eyelid issues. Conjunctival injection, proptosis, APD is present based on severity. Our other concern was for a carotid cavernous sinus fistula based on the really significant injection and tortuosity of the vasculature. So I personally gave this a 10. We'll give the diagnosis in a moment, but orbital issues like this are, in my opinion, very severe. They can result in vision loss, and then if they're untreated and there's extension to the brain or involvement of the brain, then it can lead to mortality. So that would have been the worst case scenario. For this, we referred the patient to an emergency department. In our office, we like to try to call ahead if we can. Our nurse will discuss the condition, and then we requested either ophthalmology or neurology. The patient was seen, and they had neuroimaging that showed no abnormality, but they were diagnosed with orbital cellulitis. So they were placed on intravitreous antibiotics, and they fortunately experienced a full recovery. So the big take-home message from this case, due to the risk of extension to the brain, any acute orbital disease like this generally requires urgent neuroimaging. And for a lot of patients, a lot of the ways our practice is run, emergency departments can be one of the best ways to get patients imaged quickly for this sort of thing. And then I just wanted to review some pertinent literature. So each of the cases we'll do in this format. We'll present the case, we'll do the poll, talk about it, and then just some recent literature. So this was just a large retrospective review of over 14,000 cases of orbital cellulitis treated over an 18-year period. The vast majority can be treated with medical intervention like this case, but some do require surgical management. The patient's orbital cellulitis tends to group either for young patients, so often in pediatrics, or older patients like this case, though the surgical patients were older age. The mean here, though, was 30, but there was a distribution of plus or minus 23, so significant wide age range. And then sinusitis is often the cause of orbital cellulitis. So frontal sinusitis was the most common site that was associated with surgical intervention. All right, we'll jump into the case 2. This was a 48-year-old male that presents with vision loss in the right eye suddenly. I remember this. He described it after he got out of a shower, which I think was just coincidental, but he notes that if he bent his head all the way down like this, he could see clearly. He had no significant medical history, but he did have cataract surgery in the right eye only 18 years ago. So he was 30 when he had the cataract surgery. Uncorrected vision, was counting fingers, and the refraction was plus 11, and eye pressure was normal. I have a feeling most people know what this is already. So differentials were pretty limited for huge hyperopic shift. The number 1 was a dislocated IOL. The number 2 was like a lesion posterior to the globe, which even that I don't think could cause this big of a hyperopic shift. So this was a representative image of what the slit lamp exam looked like. It really did look just like this. Only the absolute superior edge of the optic was visible, and the lens was fairly mobile. It was like shook around when the patient moved his eye. So we'll go ahead and launch the second poll here. And if everyone would consider rating the urgency of this situation on 1 to 10. This one's going to have a much wider distribution, I can already see. Oh, and I accidentally closed it early. Sorry. So if everyone can vote again. My apologies. Very wide distribution, which I think speaks to the situation for sure. All right, and we have about half of the people voting. I think that's pretty good. So we'll go ahead and share the results. So we have anywhere from 1 through 10, with a grouping kind of around the 3 to 4 to 5, but the highest preponderance here was in the 3. So perfect. And then I gave it a 4. So I kind of agree with most of this average here. So this is like a representative of what's the worst case scenario. So if that lens were to fall into the vitreous, it can cause some significant issues. So it can cause retina detachment, it can cause vitreous hemorrhage, significant intraocular inflammation, macular edema, it can lead to corneal edema, and could lead to glaucoma. The cause is loss of integrity of the lens capsule itself or the zonules. Ultimately, the patient was scheduled for emergent surgery with our cataract surgeon the next day. Due to the significance of the dislocation and the fact that the IOL was pretty mobile, we advised the patient to wear a shield at night and to limit their activities. The final result, because the capsule and the zonule complex was not intact, an anterior chamber lens was needed to be implanted. Because of the narrowing of the anterior chamber associated with that, a YAG PI was done in the post-op period. The patient ended up with a little bit of astigmatism, but overall was 20/20. So the big take home here, a patient with a severely dislocated IOL requires emergent care by a cataract surgeon. This is in contrast to a mild IOL displacement. You might see like a millimeter or 2, or even where the optic maybe is coming close to the visual axis perhaps, but there's no symptoms and there's no indication it's an acute situation. In that case, you can definitely monitor the patient. Obviously tell them to come immediately if there's any changes, but conservative monitoring is fine for a mild IOL dislocation. Once an IOL is dislocated, there are several ways the surgeon can repair it. They can do a lens rescue or reposition. So often the lens will need to be sutured, to the sclera, or less commonly the iris. IOL exchange, like in this case, is often done. If there's integrity of the zonules, then the sulcus placement of an IOL is good, and if not, then the anterior chamber IOL. And I don't know for sure. I actually forgot to ask this patient, but I think his cataract was a result of trauma, unilateral cataract at a young age, and that's likely part of the reason that led to this whole situation.
Dr. Rock, there's a question.
Oh yeah.
What is a Fox shield?
Oh yeah, cool, awesome. So a Fox shield is just a little plastic shield that a patient can tape over their eye at night. So it just goes like that. So essentially it just prevents the patient from putting any pressure on their eye at night. So we distribute these to our patients who've had LASIK surgery. So we just provide it to the patient just so he wouldn't, put any pressure on that eye while he was sleeping. Great question. And then I will say this is becoming a more common scenario, in my opinion, based on my clinical experience. I think that just about everyone who's attending this lecture probably either has seen this, or if not, will see this at some point, particularly now that patients are often undergoing cataract surgery or lens replacement at a younger age. While the vast majority of these lenses stay well centered, the longer the lens is in the eye, the higher the risk of displacement. So these were 2 studies. 2019 study looked at the frequency of IOL dislocation and pseudophacodenesis 20 years after cataract surgery. This was actually a very neat study. It was prospective, so it enrolled patients and then followed them for a significant amount of time. 39% had pseudoexfoliation, which the zonules are inherently weak. So the preponderance in this study is going to be higher than average, but still there was 60% that didn't. 20 years later, all the medical records were examined, and 1.2% of these patients had needed surgery for IOL dislocation. The mean time after their original surgery was 12 and a half years. And it doesn't go with, it's not surprising that the incidence of IOL dislocation requiring surgical attention was 3 times higher in patients who had pseudoexfoliation. And then another study, this came out of the Mayo Clinic, the county and Mayo Clinic. It was in 2018, and it looked at 80 patients who needed lens exchange over a 30-year period. 3/4 of them were for dislocated IOLs, were as a result of dislocated IOLs. And it showed that the 30-year cumulative probability of needing a lens exchange for this reason was 1.5%. So gradually increasing, as you can see on this graph here, over to the 30-year mark. So while this is pretty rare, you know, even if it's 0.1% of patients who are experiencing this, you know, it's going to become probably increasingly more common. Fortunately, it's treatable, and can anything horrible happen? Yes, but the likelihood is pretty low. And definitely, if you have any questions throughout, please feel free to pop those in the question and answer section. We'll pop on to the third case. This was a 39-year-old female that presented with significant eye pain, watering, photophobia, and vision loss. The pain level she was rating was significant, 9 out of 10, and it had been occurring for 3 days. Medical history was none. The patient was a contact lens wearer, and she reported showering in her contact lenses. Furthermore, the patient reported that she had removed her contact lens, but she was still wearing it upon the examination in the left eye. So the left eye vision was 2200, improved to 2070 with pinhole. This is the slit lamp exam. So we see significant injection, significant corneal edema, and then these pictures are always so hard to take, and then also hard to show. And I'm sure based on your monitor settings, it could look very different. But there's this ulcer here. I think you can see my mouse, but I'm circling that. It was fairly small, but it was looking to be in a ring-like pattern. Not a significant epithelial involvement, so significant pain without significant epithelial defect, and history of contact lens issues. So we'll go ahead and launch the third poll. If you would consider rating the urgency of this situation based on the information we provided. This definitely makes it more fun. So we have over half of the people voting. We have 88 people here. That's awesome. Okay, well, gonna end this and share the results. So this one kind of distributes anywhere from the whole range, but right around 8. Definitely 8 was the common number chosen here. All right. So differentials would be any type of infectious keratitis, of course. Bacterial, fungal does have a risk if there's contact lens wear. Viral could be, but often an unknown history. And then acanthamoeba, which would be contact lens wear, history of exposure to water while wearing contact lens, and then may have poor contact lens hygiene. So I gave this a 5, so maybe I'm grading a little bit lower than the audience. There's definitely a high risk, and in the retrospect, I mean, in the grand scheme of things, they can lead to significant corneal scarring. So in this upper right corner, there is a picture of a patient who did have scarring related to acanthamoeba. Cornea is one of the only structures that can be replaced. Well, we don't want any of our patients to undergo a cornea transplant. That is a method of visual rehabilitation that's not present in some of these other cases. But definitely urgent, no question about it. So we did a corneal culture, and we work with cornea specialists. So we also examine these patients together with the corneal specialists. Based on the presentation, we did start the patient though on immediate treatment for suspect acanthamoeba. The regimen that's been shown and will serve the study to be most effective is this PHMB, which I really should have brushed up on how to pronounce, but it's essentially pool cleaner. It's diluted, it's made at a compounding pharmacy, and then it's applied to the cornea with a really strong or heavy frequency. And then the patient's dilated, and then antibiotic coverage is helpful, especially at night. The patient responded very well with this treatment. 2 weeks into treatment, the PHMB was reduced to 4 times a day, and then prednisolone was added to reduce scar potential. And then 2 months into treatment, there was resolution and all the drops were stopped. And this is actually the photo of after. So the patient experienced full recovery without corneal scarring. So the big take home here, any central corneal ulcer needs to have a corneal culture completed. Obviously, it's a good idea to consider co-management or referral to a corneal specialist. And then if there is a history of contact lens wear and significant eye pain, then acanthamoeba should be at the top of the list. And perhaps we have a low threshold for considering treatment of acanthamoeba, but we do find this regimen to be highly effective. So we have had to treat several patients with this. And then I will say, I forgot to put the corneal culture results. There was no growth, which is very typical. Unfortunately, it's incredibly hard to grow or isolate acanthamoeba. So it's somewhat of a diagnosis of exclusion if you don't get bacterial growth or other fungal growth.
Dr. Rockley, I have a question.
Yeah, sure.
Did you prescribe PHMB around the clock? Did you have the patient wake up to put the drops in?
Oh, good question. No, just during waking hours. So you probably would grade that based on severity. Well, the 2200 was severe vision loss. The ulcer did appear to be in probably like a more mild presentation. So we just did the Q1 hour well awake. But I think it would be incredibly reasonable to consider having the patient wake up throughout the night and put it in. But every time I've done it, fortunately, I have not requested the patient to do that. Great question. So this is a large literature review of acanthamoeba therapies. So it looked at 227 cases of acanthamoeba. It's a very rare condition. So this is by far the largest study that ever looked at it. It looked at different agents. The cure rate, meaning the infection was completely resolved, was about 95%. And PHMB 0.02% monotherapy provided the best outcomes. The thing about it is it's often a very prolonged duration of treatment. So the median time to cure in this was 5 months. The vast majority, or pardon me, not the vast majority, about 50% had a final visual acuity of 20/80 or worse, and or required surgery. So they were considered to have a poor outcome. So unfortunately, a lot of patients will see this. And this is from a tertiary care center. So these patients are often being referred after failed treatments on other things. The important thing, my take home, is if you have a suspect acanthamoeba patient, they should be seen or treated for acanthamoeba suspect pretty quickly, because that can really shorten the course as well as allow better outcomes.
I have one more question for you. It's kind of just what you touched on, but how quick is the turnaround from the lab for culture? Would you have treated with something else if not acanthamoeba?
So yeah, the cultures are incredibly slow. The scrapes do come back like the next day normally, so they'll do staining and they can identify if there's any gram-positive or gram-negative bacteria. The actual growth on plates can take weeks. It does take weeks. We work generally locally with the hospital, and they will send reports very frequently. So usually we'll get a report every 24 hours. But the final reports usually take 3 to 4 weeks. Fortunately, we've treated, I know, like probably 1 to 2 cases of this a year. And if you treat this, even if it's suspect, even if you're not sure, I think with this regimen, kills pretty much anything. So obviously you don't want to treat anything you don't think is acanthamoeba this way, but if you do think it's acanthamoeba, this is an effective treatment for sure. And I feel it would kill other things if it's incorrect, but all right, so let's jump on to the next case. We're halfway through the cases. Case 4 is a 73-year-old male with concern of blurred vision in the right eye. He reports loss of the lower part of his peripheral vision, denies any retina detachment symptoms. He did have an ocular history for cataract surgery 1 month prior. Medical history, he had significant risk factors of high blood pressure, diabetes, high cholesterol. The vision in the right eye was 20/30. It's pretty good, but it didn't improve with refraction, and eye pressure was normal. There likely was an APD. I guess we didn't do good documentation there. So differentials at this point would be retina detachment, ischemic optic neuropathy, retinal artery or vein occlusion. There's plenty others, but those would be the top ones. So this provided some further information. The OCT was done more for documentation and tracking purposes, but it's very obvious that there's significant edema of the disc. So the way we know that on OCT is looking at the RNFL thickness, which would be significantly outside of the normative range, double or triple in some areas. And then at the actual scans here, we see extension from the nerve in this V-type shape of edema. Well, what we would believe to be edema, a cuff of the fluid, but it does create that V shape that extends from the definition of the nerve out into the retinal nerve fiber layer. And then a visual field was done at a later date, and it showed inferior altitudinal defect. So patient's age was 73. So how would everyone rate the urgency of this situation based on only this information? We need more information, but well, thank you again for joining and for participating in these polls. It definitely makes it a little bit more fun. All right, so we have over half again. So pretty equal distribution around 7. So 7 ranking up to 10, going down to about 5. And I'm in good agreement with that. So I gave it a 9. So at this point, we know it's in ischemic optic neuropathy, but we don't know why. The concern in a 73-year-old male would be for giant cell arteritis, which can lead to significant other issues. So GCA can lead to significant vision loss, involvement of the contralateral eye, brain aneurysms, and even stroke. So it's definitely a big item of concern. So this upper right photo is not this case, but it shows another patient who had GCA associated with ischemic optic neuropathy, and it involved both eyes. So the plan, I asked the patient carefully about GCA symptoms. They're all listed here, but of course, headache, jaw claudication, which would be the weakness when chewing, scalp tenderness. I always palpate these patients and see if they have any muscle or joint ache, just generally not feeling well. It's very important to note, though, that, and we'll review again, that 20% of patients can have GCA with ophthalmic manifestations and have no systemic symptoms. So for these patients, they require immediate lab work, ESR, CRP, and CBC with platelets. So we ordered that. And fortunately, in this case, all of that was normal. So the CRP came back, it was low, normal, and the ESR was low and normal. So that along with negative symptoms, essentially rules it out. So the patient then was diagnosed with a non-arteritic ischemic optic neuropathy. We all know there's really not any established treatment for this. There is an ongoing clinical trial called the Nordic trial, and it's looking at an intravitreal injection for treatment of non-arteritic ischemic optic neuropathy. You can put that in Google and find the closest clinical trial site to you. We actually did refer the patient there. They wanted to go. Unfortunately, based on his history of cataract surgery, he didn't qualify. So we ended up following him in our office. But the patient was fortunate to do very well. There's a huge range of what can happen. Of course, with these, the patients can experience significant vision loss or do fairly good. I still see him pretty often. He's 20/30, and he does have this inferior visual field defect that, of course, is not going away, but he is fortunate to not have any further involvement or further loss of vision. If it truly is an arteritic ischemic optic neuropathy, the patient requires immediate high-dose steroids, often treated by a neuro-ophthalmologist or a rheumatologist. So it's often done via hospitalization with IV. And then, of course, a temporal artery biopsy is ordered to do a confirmation of the diagnosis.
Dr. Rock, there just was a comment regarding the case, and just in addition to adding the APD, it may be helpful to note if the cataract surgery was bilateral or which eye 1 month ago.
It was bilateral. Yes. Yes. And there definitely would have been an APD. I'll have to go back and review. I should have put that in there though, but there would 100% have been an APD. So just a brief review of GCA. Again, we've already talked about it. Ophthalmic manifestations, 8 to 28% of patients with GCA can experience permanent vision loss. 20 to 60% have bilateral vision loss. So this reiterates the need for prompt diagnosis and treatment to try to prevent involvement of the contralateral eye. Ischemic optic neuropathy is the major player in the vision loss, so it's responsible for 80 to 90% of vision loss in GCA patients. Other players would be central retinal artery occlusions, cilioretinal artery occlusions, and then it can cause transient vision loss or cranial nerve palsies in this listed order. The big take home though is immediate ESR, CRP, and CBC with platelets is needed for any patient with an ischemic optic neuropathy or central retinal artery occlusion greater than age 55. And it should be considered for all the other listed conditions here as well, such as the cilioretinal artery occlusion or cranial nerve palsies, depending on the clinical picture. And then this was a paper that looked at the incidence of arteritic ischemic optic neuropathy and vision loss with GCA. It was a retrospective study of 245 cases of GCA. 8.2% had permanent vision loss, and of those, 20% had vision loss without any systemic symptoms. And then the breakdown was very similar to what we just had seen in the prior. The majority was from ischemic optic neuropathy, central retinal artery occlusion, and then cilioretinal artery occlusion less commonly. But the big thing would be just because they don't have symptoms doesn't mean they don't have GCA. So definitely need to be treated like it is possible. Okay. All right. And then case 5, 51-year-old Asian male with 24 duration of eye pain, cloudy vision. He notes it's worse when bending over. He does report some intermittent bouts of blurred vision in the past. The vision in that left eye was 20/50, and then the eye pressure was 45. Differentials for any significant rise in IOP: acute angle closure is number 1, inflammatory glaucoma, retrobulbar hemorrhage or inflammation, or pigmentary glaucoma. All of these can cause an acute rise in eye pressure. The slit lamp exam, though, showed mid-dilated pupil, conjunctival injection. The gonioscopy in the left eye, there were no structures visible, and then the right eye gonioscopy showed a narrow angle. There was a CD ratio of 0.6 in both eyes. So for this one, urgency, if y'all would consider rating this, 1 to 10, 10 being the worst. IOP was 45. We're going to get a pretty wide variance here again. All right, awesome. So most common here was 8, with a pretty even distribution around all the way down to 5, 5 and lower, and then up to 10. And I think those are all very legitimate answers. But myself, I gave this an 8. Acute angle closure glaucoma, as we all know, has risk of severe damage to the optic nerve that can occur within hours in certain circumstances. It can lead to significant vision loss, like the visual field that's represented here in the upper right corner. If the visual acuity is hand motion or worse, the IOP reduction is considered a true emergency. If the visual loss is less severe and the IOP is lower than 50, it's considered an urgency, like this circumstance. So the patient, essentially, we threw the kitchen sink of topicals and orals at the patient. So timolol, brimonidine, acetazolamide, 250 milligrams, so the fast acting, and pilocarpine. Checked the IOP 1 hour later, it was 42. More topical agents were administered. 45 minutes later, it was 37. So it was not coming down significantly. Then there was not significant corneal edema. So a YAG PI was able to be done that day. Immediately, the IOP lowered to 23, the anterior chamber deepened, and the iris approach flattened. So the patient was discharged with anti-inflammatories and then pretty much all the reasonable topical and oral agents to make sure the eye pressure is kept under control. Fortunately, the next day, the IOP was 7, and then a YAG PI was done a few weeks later in the right eye. So angle closure, glaucoma management. The big thing, of course, is attempt to lower the IOP using any and all reasonable available agents. So beta blocker, alpha agonists, carbonic anhydrase inhibitors, specifically orals. Topical steroids sometimes can help with if there's inflammation. And then osmotic agents like glycerol or mannitol can be considered if you have availability to them. If it's phakic pupillary block, they should also get pilocarpine. But if it's pseudophakic, then it's the opposite. They should get mydriatic, because a mydriatic is going to encourage posterior, essentially rotation of the ciliary body, which should open the angle if they're pseudophakic. So if IOP decreases significantly and the angle opens, YAG PI is done once the cornea is clear and the chamber is quiet. So this is generally 1 to 5 days. So if the attack can be managed medically, then it can wait for the YAG PI. If the IOP does not decrease after 2 courses of maximum medical therapy, then a YAG PI should be done if there's adequate view of the iris. So that's what we did in this circumstance, because it was not lowering with the topical and oral agents. And then the patient should be discharged, essentially with anti-inflammatories and then agents to control the pressure. So this study, 2016, it was the EAGLE trial. So effectiveness of early lens extraction for the treatment of primary angle closure glaucoma. It was a pretty large, randomized, controlled, prospective study, 419 participants. There was a mix of either primary angle closure without glaucoma or primary angle closure with glaucoma. 208 were randomized for clear lens extraction, and 211 were randomized to the standard of care, which is a YAG PI. It did show that the clear lens extraction group had a lower IOP. They required less drops to control IOP. less additional surgery, and then it looked at quality of life and cost effectiveness and found that to be better as well. So there are certain surgeons and certain groups of thought that are tending a little bit more towards this, particularly if the patient, of course, is presbyopic, older, closer to the cataract age, doesn't require cataract surgery yet, but maybe won't have their natural lens for much longer either. So definitely a good consideration, and is becoming an possible alternative to the standard of care, which is the AGPI. All right, case 6, 63-year-old female, concern of gray smear in the superior visual field in the right eye, describes it like a curtain. She's seeing some flashes, she's seeing floaters, and it's been going on for 3 to 4 months. Ocular history of cataract surgery in both eyes 1 year prior. The family history, the father had a bilateral retinal detachment. Patient himself had rheumatoid arthritis. Vision was fair. IOP was normal. Dilated exam was done. Differentials are many, but perhaps the major ones would be PVD, retinal detachment, retinal tear, or retinal vascular occlusion. The imaging we have to share here is obvious on the dilated exam, but seeing something abnormal looking in the inferior quadrant of the right macula, and when scrolling through it is obvious detachment of the retina. So how would we rate the urgency of this situation? I'm gonna launch the poll here. So duration was 3 to 4 months, and it was in the inferior quadrant. So that was my little last push. I shouldn't have said that. I feel like the distribution just started to change. But I think any of these answers are legitimate, to be perfectly honest. It's sometimes really hard to know how to triage and manage these cases, how urgent they need to get in with retina specialists, etc. All right, awesome. So 7 was the most common, with a pretty equal distribution down to 3 and up to 9. Oh, let me share those. So 7, down to 3, up to 9. Okay. And I gave it exactly that, a 7. So it's a retina detachment. It's risky, even if it's been going on a while, or even if the symptoms have been going on a while. We don't actually know that the retina detachment's been there that long. Could be very new. The risk, of course, is significant loss of vision, greater for the superior detachment versus inferior, and greater if the macula is on, because the macula could then detach versus the macula being off. So the risk is higher because the macula is on in some ways. So the patient was referred to a retina specialist who saw them the next day. They were educated not to eat after midnight. They had emergent surgery performed the next day. In some cases, OCT can be helpful if it's unclear if the macula is attached. The patient had good vision, so it was pretty clear. And then obviously a retina detachment requires emergent referral to a retina specialist. You want to get a hold of a retina specialist the day of, but if at all possible. But if it's macula on, it's generally treated within 24 hours. If it's macula off, it's generally treated within 7 days. And then this was a pretty neat study I found, 2018. It looked at metamorphopsia and OCT changes in macula off versus macula on retina detachments. So it was a prospective study, because they administered these charts after patients had had a retina detachment repair. It was 40 eyes that had retina detachment. Macula off was 26%. Macula on was 26 eyes, excuse me, and macula on was 14 eyes. Without any, obviously the patients who had macula off experienced more metamorphopsia, so it was 88% and versus 21% with macula on. But the big take home here, I've had some patients that have been fairly devastated by their vision after a macula off retina detachment. But one interesting thing here is that you can reassure these patients that sometimes their vision will indeed get better. And this study showed that. So 88% had metamorphopsia at 6 months, but it decreased to 64% at 12 months. So we all know that our retina specialists always will tell patients it will generally get better, and this just is one other evidence to support that. All right, I need to speed up. We have 2 more cases. So 61-year-old female, sudden vision loss in the right eye. They were doing well before then. They denied any pain, redness, or any other symptoms. So other than vision loss, that was really their only symptom. So that's important to remember here. Ocular history, they had had cataract surgery 5 days prior. Their vision present exam was counting fingers, pinhole to 2,500. Previously, their post-op day 1 vision was 20/25, so it was a big reduction. Differentials, endophthalmitis, toxic anterior segment syndrome, or of course any retinal or nerve issue. Anterior segment evaluation showed just what the patient described. There was no significant redness, but there was a 10% hypopion, fibrosis on the lens, 2+ cells, and 2+ corneal edema. So let's rate this one. Awesome. All right. So we're distributing right around 8, going up to 10, down to 5, but the highest distribution 8, 9, 10, 7. So I'm right there with y'all. So gave it an 8. The concern was for endophthalmitis, of course, given the hypopion. 5 days after cataract surgery, significant decline in the vision. The risks of endophthalmitis are significant. So this is a patient that had endophthalmitis, not this patient. There's a case in the literature that experienced ptysis bulbi. So obviously the risk is higher. And then this is from when I've referred some of these patients over. Severe vision loss upon presentation is going to unfortunately not do as well as mild to moderate vision loss. Is what my retina colleagues have told me. It can damage all intraocular structures, of course, so the risk is high. So immediately referred to see a retina specialist. Injections into the vitreous were done. The patient was put on oral moxifloxacin, which shows really good vitreous penetration and anterior chamber penetration as well. So that's a good take home here. That's a really good oral antibiotic if you're looking for those sort of properties. They were put on topical antibiotics, frequent steroids, and cycloplegia. The patient made a very quick recovery. So the vision, then 1 day after treatment, already had improved to 2,200. By day 6, it was down to 20/40, and then the final vision was 20/20. The only noticeable effect was mild atrophy of the iris. So a big thing here is going to be differentiating endophthalmitis from toxic anterior segment syndrome, because they do have similar properties but need to be managed very differently and lead to very different outcomes. Endophthalmitis obviously is an infection, generally bacterial, it could be fungal. It onsets generally a little bit later, as in 2 to 7 days, but it can be rarely even weeks down the line. So that needs to be considered for persistent inflammation that's lasting beyond several weeks. It's generally painful, but some cases occur without pain. There is going to be vitreous inflammation, and cultures will be positive. It generally does not group, so it would be like one patient experiences this out of the blue. And then the goal, of course, is to fight infections. So if it can be managed with intravitreal, oral, and topical antibiotics, then that's how it's done. If not, patients can require vitrectomy to physically remove the agent from the eye. In contrast, we're looking at toxic anterior segment syndrome. It's inflammatory, related to a substance that could be encountered during surgery. It onsets pretty acutely, so 12 to 24 hours, generally without pain, so just significant inflammation. There won't be inflammation of the vitreous, so that's the anterior segment part. And it does often cluster on same surgical date. So one or more patients can experience this altogether. The goal is just to suppress inflammation. So topical steroids are done very frequently. And I've noticed retina specialists often will treat endophthalmitis with significant topical steroids just to provide coverage in the off chance that it is, before they get the culture results, if it is more of a TASS situation. But endophthalmitis presents significant risk to ocular structures. Anytime there's concern for endophthalmitis, treatment is started. Sometimes steroids are done at the same time if there's a concern for TASS. And then any case of endophthalmitis or TASS requires immediate treatment, and it's a good idea and often to get a retina specialist involved. This study looked at outcomes of a huge cross-sectional study. So it was published in 2016, showed low incidence of endophthalmitis, so 1 in 4,000-ish. Risk factors are the big thing to take home here. Diabetes, older age, 81 was the mean. If there is any complication like a rupture of the posterior capsule, that's a much higher rate. If the patient requires extra capsular cataract extraction, or if there's surgery actually on the left eye, which was statistically significant. And it just has to do with the incision location. On the left eye, often right-handed surgeons make it more superior. All right, so we have to go like a rapid fire on this case 8. So 26-year-old female presents for a routine eye exam, but they did have concern of headaches. They were frontal, relieved by over-the-counter medications. No known medical history, vision was good, pupils were good, blood pressure was normal. The patient's BMI though was 32. So just to review, BMI here, normal being like 18 to 25-ish, obese 30 plus. The patient though did on dilated exam show disc edema that was worse in the right eye than the left eye. So very similar to before, there was a fluid cuff outside of the nerve extending in a V-shaped pattern, much easier to see on the right eye than the left. And then the RNFL thickness was significantly outside of average, particularly on the right eye. All right, we're gonna do this poll for like a really short time. It's like 20 seconds, so vote fast if you wanna vote. All right, and then I'm going to provide one level of, or one instruction while we're waiting on this, which is if you are joining the next talk, which is on the low vision by Dr. Ho, I hope you all join. Just be sure to use your unique join link to join as quickly as possible after I end this, and I'm going to wrap this up real fast. All right, so urgency here was tied. 5 and 7, and then distributing all the way up to 10 and as low as 3. So that's interesting. I mean, definitely this is a hard one, I feel, to know just the level of urgency. This is just going to be a photograph of this. Do a screenshot, grab your phone. I just compiled pretty much any bilateral disc edema differential. So ultimately, this could be an entire lecture, and I've intended entire lectures on this, but papilledema, which is true intracranial increase in pressure causing bilateral disc edema, but others would be malignant hypertension, infectious, inflammation, infiltration, such as a carcinoma, medications. Any cause of unilateral disc edema can cause bilateral disc edema, and then pseudopapilledema. So snapshot that. We will post this lecture online too if someone, if you were interested and didn't capture that. An MRI was ordered. It showed several different things, but the most pertinent was a Chiari, or Arnold Chiari is often called malformation. And then because of that, the concern was for true papilledema because there was a brain abnormality. So I gave this an 8. The risk is significant vision loss. In some cases could lead to mortality. Acute is worse than long-standing, so this was more of a long-standing. And then reduced vision is greater than asymptomatic. So even that I'm saying I maybe should have graded it a little bit lower. But the outcome, Chiari-1 malformation is a congenital malformation marked by a displacement of the cerebellar through the foramen magnum. And so there's a picture of that here. It most commonly presents with symptoms of headache that can be very similar in nature to those with idiopathic intracranial hypertension, which was my prime diagnosis in this case because the patient was overweight. The patient was referred to a neurologist for further evaluation and treatment. And then the big thing here is any patient with bilateral disc edema should have their blood pressure taken because that's one of the big differentials. And then emergent neuroimaging is then needed. Recommended MRI with and without contrast and MRV of the head is preferred, but if MRI is not available, then a CT scan with these views is acceptable as an alternative. And then this was a big trial that looked at optic nerve head edema in patients presenting to the ER. It was prospective. And so it followed 1,400 patients with complaints of headache, neurological defects, vision loss, or high blood pressure. And it showed that among these patients, 2.6% had disc edema. The majority of that was bilateral. So the big thing here is presenting symptoms that this presented to an emergency department, so not primary eye care, was headache and vision loss. The final diagnosis in these cases was often idiopathic intracranial hypertension, which we know is often associated with obesity and more common in females than males. And then associated risk factors were BMI greater than 35, younger age, and vision loss. Another non-exhaustive list of emergencies and emergencies that we reviewed. Snapshot this one super fast. Ultimately, signs and symptoms can take one from an emergency to urgency and vice versa. So this is non-exhaustive. It's not meant to review everything. The ones in red are the ones we reviewed today. And conclusions, any of us can encounter ocular emergencies. It's helpful to gauge the risk level to help with triage and management decisions. How soon to get to the patient in the office? Can the condition be managed by us, or do we need to get another specialist involved? Do you want to order your own lab work or neuroimaging, or have another specialist help with that? Thank you all. I'm sorry I had to wrap this up so fast, but did want to cover a lot of stuff. Do we have any other questions?
No, we're all good here.